Glutathione, acetaminophen, and alcohol. Acetaminophen toxicity is one of the most common cause of poisoning worldwide. In America, it's a common cause of acute liver failure. And if the liver failure occurs, liver transplantation is the only treatment. The acetaminophen is metabolized normally by conjugation with glucuronides and with sulfates. These two are the non-toxic pathways excreted by the liver. The third pathway of acetaminophen metabolism is by mixed function oxidase of the liver, and that converts acetaminophen into a toxic substance NAPQI, N-acetyl P-benzoquinone imine. NAPQI, if in excess, normally only a 10% dose of acetaminophen is converted to NAPQI, which is toxic and is easily removed by glutathione, which converts the toxic NAPQI to cysteine and mercapturic acid conjugates, which are non-toxic. So where does the glutathione comes from? The glutathione is formed from glycine, and this is low. Glycine is low in illness and fasting, and also is formed from cysteine and glutamate. So all these substances are responsible for the formation of glutamate, which converts toxic NAPQI to a non-toxic form. So the glutathione is in the two forms, a reduced glutathione and an oxidized glutathione. It is the reduced form of glutathione that converts the toxic NAPQI to a non-toxic form, because NAPQI causes oxidative cell damage to the liver cells. The oxidized glutathione is converted to reduced glutathione by glutathione reductase, and the electron donor is NADPH and is converted to NADP. Then the reduced glutathione, when it donates its electrons to the NAPQI, it's converted back to oxidized glutathione by glutathione peroxidase. So what does the glutathione does? Glutathione is an antioxidant that serves as an electron donor, and in the process it's converted to oxidized form, and then, as I told, it's converted back to the reduced form by NADPH that donates the electron. Glutathione is synthesized in the body from amino acids L-cysteine, L-glutamic acid, and glycine. So two forms, reduced and the oxidized form. The reduced form donates electron to convert NAPQI to a non-toxic form. More than 90% of the total glutathione is in the reduced form. Glutathione prevents damage to the important cellular components caused by reactive oxygen species such as free radicals and peroxides. So what are the functions of glutathione? Glutathione is the major endogenous antioxidant produced by the cell. It neutralizes the free radicals and reactive oxygen compounds. It maintains exogenous antioxidants such as vitamin C or ascorbic acid and vitamin E in their reduced or active form. It is used in metabolic and biochemical reactions such as DNA synthesis and repair, protein synthesis, prostaglandin synthesis, amino acid transport, and enzyme activation. Glutathione participates in leukotriene synthesis and is a cofactor for the enzyme glutathione peroxidase. It is also needed for the detoxification of methyl glyoxal, a toxin produced as a byproduct of cell metabolism. Calcitriol or 1,25-dihydroxycholecalciferol or active vitamin D3, which is produced by the kidney, increases the glutathione levels in the brain and appears to be a catalyst for glutathione production. So when do we see low glutathione? Number 1, wasting. Number 2, negative nitrogen balance as seen in cancer, HIV, AIDS, sepsis, trauma, burns, and athletic overtraining. The glutathione ascorbate cycle is a metabolic pathway that detoxifies hydrogen peroxide, which is a reactive oxygen species that is produced as a waste product in metabolism. The cycle involves the antioxidant metabolites ascorbate, glutathione, and NADPH, and the enzyme linking these metabolites. Conditions with decreased glutathione reserves are alcoholism, childhood, acute starvation, chronic malnutrition, and possibly conditions with increased cytochrome P450 activity that occurs with anticonvulsants and with anti-tubercular drugs. One more insulin glutathione enzyme. The hepatic glutathione insulin transhydrogenase breaks insulin molecule into its A and B chains in insulin metabolism for its degradation. NAPQI causes liver cell necrosis. Normally only 10% of the acetaminophen dose is metabolized through mixed function oxidase system to form NAPQI, and this NAPQI is detoxified quickly by binding to reduced glutathione to become the harmless compound as mercapturic acid and cysteine conjugates. Toxicity occurs when NAPQI is formed in excess and when glutathione levels are low and depleted and permitted to bind covalently to the nucleophilic hepatocyte macromolecules, leading to hepatocyte necrosis. NAPQI causes centrilobular hepatic cell necrosis. The causes of liver injury are heavy acetaminophen dose. Hepatic injury may be potentiated by prior administration of alcohol or other drugs, and the conditions that stimulates mixed function oxidase system, or by starvation that decreases hepatic glutathione levels. One important drug, cimetidine, inhibits cytochrome P450 enzyme, and that has the potential to decrease the generation of toxic metabolites. How alcohol does liver damage? That alcohol induces cytochrome P450 and one of its isoenzyme 2E1, and that increases the level of NAPQI that causes the liver cell damage. In chronic alcoholics, in addition, alcohol suppresses the hepatic glutathione levels. Therefore, in chronic alcoholics, the toxic dose of acetaminophen may be as low as 2 grams. This occurs in patients with severe febrile illness or pain syndromes, on several days of anorexia and near fasting, coupled with regular administration of extra strength acetaminophen. This results in a combination of glutathione depletion and high NAPQI levels. In alcoholics, the acetaminophen toxicity does not occur when the alcohol is in the system, but the toxicity occurs during the withdrawal period, that is about 18 to 36 hours after stopping alcohol. Because alcohol does two functions. Number one, it induces cytochrome, one of the isoenzyme of cytochrome P450, that is 2E1. It induces that, and also it inhibits the acetaminophen metabolism. So as long as alcohol is present, this metabolism is inhibited. But once it is gone, the enzyme is already induced, so it causes excess production of NAPQI that causes cell damage. How different drugs cause hepatic necrosis. Alcohol induces hepatic microsomal mixed function oxidase cytochrome P2E1 and 3A4. This is present on the smooth endoplasmic reticulum, and this system is responsible for the metabolism of many drugs. The reactive metabolites covalently binds to tissue macromolecules, causing tissue damage, and binding often occurs close to the site of production. That is why liver cells are damaged. Number 2, INH. INH or isoniazid induced hepatic toxicity is due to the production of metabolite acetylhydrazine, which is then metabolized by mixed function oxidase and liberates a reactive metabolite that covalently binds to hepatic macromolecules, causing necrosis. Drugs that increase the activity of mixed function oxidase system, such as phenobarb, rifampicin, together with INH, results in the production of increased amounts of reactive metabolites, increased binding, and a greater risk of hepatic damage. Other drugs that cause hepatitis and toxic necrosis are, amongst them, number 1, immunosuppressive. Amongst the immunosuppressive is azathioprine. Number 2, amongst the lipid-lowering drugs are nicotinic acid and lovastatin. Amongst the hydrocarbons, carbon tetrachloride, metal, yellow phosphorus, and a mushroom that causes hepatic necrosis is Amanita phylloides. It is important to note that NAPQI causes liver cell damage only when glutathione reserves are depleted completely. The risk of liver injury is increased in patients receiving phenobarbital that increases the production of toxic metabolite. An idiosyncratic reaction, which is not dose related, may also cause covalent binding and toxicity. So, how acetaminophen causes the hepatic necrosis? Acetaminophen causes centrilobular hepatic necrosis because of the excess production of NAPQI, and it is taken, a heavy dose is taken accidentally or intentionally for suicidal purposes. But in chronic alcoholics, the toxic dose is much lower. A heavy dose of 10 to 15 gram when ingested causes centrilobular hepatic necrosis. A fatal fulminant disease is caused by 25 grams or more. A blood acetaminophen level of 300 microgram per milliliter 4 hours after the ingestion is indicative of severe damage, and a level less than 150 microgram suggests that hepatic injury is highly unlikely. The chances of possible, probable, and high-risk hepatotoxicity is derived from a normogram plot on a 24-hour duration ingestion. The lower lines, anything above this lower line is indicative of toxicity. So what is the normal values of acetaminophen in the blood? The volume of distribution for acetaminophen is 1 liter per kg, and a normal plasma concentration is 5 to 20 microgram per milliliter. NAPQI rapidly metabolized by conjugation with glutathione as cysteine and mercapturic acid conjugase. The glucuronyl pathways, which are the major pathway for acetaminophen metabolism, become saturated on a level of 140 milligram per kilogram of body weight, where sulfate and glucuronide pathways become saturated and NAPQI is formed in excess because mixed function oxidase system form more and more NAPQI. When all glutathione stores are used, NAPQI then binds covalently to the hepatocytes, causing centrilobular necrosis. A level of acetaminophen of more than 200 microgram per milliliter at 4 hours or a more than 100 microgram per milliliter at 8 hours after ingestion are indicative of damage. The treatment of toxicity. Number 1, gastric lavage. Number 2, activated charcoal or cholestyramine in the first hour of ingestion. Charcoal does not inhibit the function of N-acetylcysteine. The third treatment is cysteine or N-acetylcysteine. They reduce the hepatic necrosis, and these agents to provide sulfhydryl group to bind the toxic metabolite. And number 2, they increase or stimulate the synthesis and repletion of hepatic glutathione. Methionine is also used as an alternate for N-acetylcysteine. The treatment should begin within 8 hours, but may be effective even if given as late as 24 to 34 hours after the overdose. So the loading dose of N-acetylcysteine is 140 milligram per kg, followed by 50 per kg every 4 hours for 15 to 20 doses. Survivors usually have no evidence of hepatic sequelae. What are the side effects of acetylcysteine? The most common side effect, which is almost always present, is vomiting. So metoclopramide should be added. The most dangerous side effects of N-acetylcysteine is shock. The clinical features. The early clinical features within 2 to 4 hours. Nausea, vomiting, diaphoresis, pallor, and hypotension. The features within 24 to 48 hours are that of hepatotoxicity with right upper quadrant pain and tenderness and mild hepatomegaly. The liver toxicity or necrosis may occur 6 to 8 days after ingestion of the drug if the treatment is not taken. The lab findings: prolonged prothrombin time, increased serum bilirubin, increase in transaminases activity, aspartame transaminase and alanine transaminase. The indicators of poor prognosis are greater than two-fold prolongation of prothrombin time, serum bilirubin more than 4 mg per 100 ml, pH less than 7.3, serum creatinine more than 3.3, and a high-grade hepatic encephalopathy. Alcoholics may present with a syndrome of severe combined hepatic and renal insufficiency with dehydration, jaundice, coagulopathy, hypoglycemia, and acute tubular necrosis. Acetaminophen may also cause cardiomyopathy. AST levels of more than 1000 international units per liter are more likely to result from acetaminophen poisoning than from chronic hepatitis or alcoholic liver disease. The poor prognostic indicators at 24 to 48 hours post-ingestion are pH less than 7.3, INR more than 3, prothrombin time more than twice, serum bilirubin more than 4 mg per 100 ml, serum creatinine more than 2.6, hepatic encephalopathy grade 3, that is confusion and somnolence, or grade 4, stupor and coma, and hypoglycemia.